Well, good morning, everybody. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Welcome to today's webinar, Busting the Ghost Provider Problem, Solutions for Now and the Long Term. This is one of many webinars and forums that HPA hosts to keep our members up to date on issues affecting our industry. So thank you for taking the time to join us today. And a special thank you to Leap Orbit, an HPA affiliate, for sponsoring today's session. Now, as many of you know, at the end of last year, the New York Attorney General, Letitia James, released a report on the adequacy of health plan provider networks. Now, our industry takes seriously its obligation to comply with both state and federal mental health parity laws and does as much as we can to ensure that the network provider directory information is as up to date and as accurate as possible. But we recognize that there's more work to be done and that there's a responsibility on the part of both health plans and providers to make sure that that information is up to date. Now, following that report, we have a group of provider data experts who took a look at the information, sort of our AKA our Ghostbusters today, and they got together to study this issue and identify potential solutions. Now, during today's session, the Ghostbusters will present the results of their initial study looking at over 300 behavioral health providers in network at various New York health plans. And these results are expected to reveal the opportunity to predict ghosts and present an action plan for correcting them. Joining us today is Jake Tooney, the Director and Payer Solutions at Leap Orbit. Jake leads the go-to-market strategy for Convergent, the first FHIR-native provider data verification platform, and he specializes in data-driven strategies to optimize provider networks. With him are some of the folks that they work with, including Gary Balnick, the president, and Neetha Devo, the provider outreach specialist of Command Direct, which specializes in delivering seamless, secure, and multi-channel member-provider communication. Also with us is Ron Irwangzi, who's the co-founder of De Facto, which specializes in healthcare provider data interoperability, transparency, product management, and software development lifecycle solutions and strategic partnerships. And finally, we have Michael Stratton, who's the founder and CEO of Health Data Atlas, which is a leading provider of healthcare affiliation data and aggregates claims for over 300 million patients. Now, before I turn the session over to Jake, a couple of reminders. We wanted to let you know that there will be an opportunity for Q&A at the conclusion of today's presentation. This is an interactive session, so if you wish to submit a question, enter it in the chat function that you'll find at the bottom of your screen, and we'll try to get to as many questions as we can over the course of the next hour. We are recording today's session, and following the session, we'll send out a copy of both the presentation and the recording in case you have questions or wish to follow up with the folks at Leap Orbit. So with that, thank you all again for joining us, and I'll turn the session now over to Jake. Good morning, Jake.
Good morning, Eric. Thank you so much for having us here today. And, you know, when we first started talking, I had a totally different idea for what to talk about. So thanks for helping steer me in the right direction and helping really align with the interests of your members. So thanks, Eric, for having us and looking forward to getting into the agenda. And as Eric mentioned, this will be interactive. So before I kick in, I have our first sort of poll question to type in the chat or wherever typically it goes for these type of webinars. In your opinion, what causes ghost providers to occur? So in your experience, in your opinion, what have you seen that typically creates this challenge of the ghost provider? So apologies in advance for the overuse of the Ghostbusters metaphor. Huge fan of the movie, and it's clearly an apt metaphor for today, and excited to dive in. So for our agenda, I'll introduce, well, we already introduced the expert panel of provider data experts. We've got some really great folks here today. We'll talk about the challenge of provider ghosts, especially behavioral health ghosts. And then we'll walk through the results of our New York case study, lessons learned and observed while conducting that case study, and a look to the future for innovations we can implement that resolve the ghost provider problem once and for all. And then finally, we'll have some Q&A. I expect that to be very lively and have a lot of feedback and interaction between our panel of experts here. So this is the classic image of the Ghostbuster pack where all the ghosts in Ghostbusters get sucked into. And this is really what we do at Leap Orbit with our data product convergent. We find the ghosts, bottle them up, just like in the movie. So what if we could do this in an efficient, reliable, cost-effective way? Well, that's what we're going to discuss today with the case study, how we can think about eliminating the ghosts, and if appropriate, even bring the ghost back from the dead into a real living provider and find other real living providers to help fill the gaps left by sussing out these ghosts. Okay, so let's whiz through these slides as we already went through the intros. So let's talk briefly about the challenge. I won't belabor this since I know most of you are intimately aware of this challenge. And obviously there's a lot of focus lately on behavioral health providers, I think for a good reason. And I thought this stat was really good at summarizing the issue, that more than half of insured adults who do not get needed mental health treatment cite lack of coverage by their health plans as the reason. So while we're focusing on behavioral health providers, the problem of ghost providers exists throughout the networks for all provider types. Just with the COVID epidemic or pandemic, we've seen a dramatic increase for the need of mental health service, and there's a big spotlight on this issue. But I think what's not talked about enough is an inherent tension between accuracy and adequacy, where you essentially have two competing regulatory priorities. You have things like the No Surprises Act and CMS Secret Shoppers looking at accuracy. Meanwhile, you have adequacy requirements requiring the maintenance of certain thresholds and numbers of providers in the network. So that really makes this a complex problem. So many different stakeholders, and accuracy is often at odds with adequacy. So payers have to solve both sides. And we'll talk more about how we do that today. Meanwhile, another key stakeholder here, obviously, is providers who more and more are suffering from provider abrasion. We hear about this a lot. And some of the key elements that we see here are multiple attestation requirements where providers are constantly being asked to update data through different locations, different sites, different reports that are all being asked them to keep up to date. And especially behavioral health providers often don't have the administrative infrastructure to keep up with that. They're not always part of a large provider group, things like that. Meanwhile, you have issues with credentialing enrollment and challenges there, sort of administrative challenge, although it's sort of, embedded within the natural aspects of the health plan and provider relationship, still is an administrative challenge. And then what we hear from talking to different behavioral health providers is, there's a long-term challenge to keep providers accepting new patients as reimbursement rates sometimes lag private pay. So that's another conflicting thing that I feel like we do need to bring up here. So let's get into the case study. So before we do, I have another audience poll. How do you find ghosts today? Is it through member complaints, other verification processes, etc.? So that would be something else we'd be curious and can help dig in on within the Q&A. And so before I hop into the results of the case study, I wanted just to set the table with a definition for what is a ghost. So option A may or may not exist. Option B is the definition that we've aligned on for the purposes of this study. So option B, a provider listed in a health plan's public directory that a member cannot book an appointment with the information that's present. So, ghosts are a real problem in the network, and, they have financial impacts. They threaten members. There's claims issues associated with them. So I think if we could collectively make them go away, everyone would do a victory lap. So that's what I'm hoping to showcase today is, how we can do that. And so part of the case study is our methodology. So underlying the study, we used our automated provider data product, Convergent. And Convergent really leverages a paradigm shift away from relying on abrasive attestations to using trusted third-party data sets, so what we call reference data, to enrich and verify provider networks. Basically, it gives us the ability to take in a vast array of provider data sources to help analyze a network and surface ghosts. So the data that was used for the study are claims data, so both Medicare and commercial, Medicaid data, so the MMIS system, New York Medicaid files. We also get sanctions data, web scrape data from Google. We often find providers update their web listing before they update their health plan data. Typical primary sources like licensure data. And we also use FHIR APIs. So this is where the folks at De facto Health specialize in bringing those FHIR APIs together and helping create the actual sample of behavioral health providers that we would run our analysis on. So, right, so this is how we identify the ghosts. And so all of this can be baked in as part of a No Surprises Act verification process. But what we did was we took the network list and bumped it against our golden records. So golden records is sort of a terminology that we apply to all of these data sources. Once they're algorithmically mastered within Convergent, we essentially surface them as golden records via API, so we can perform lookups between the Convergent data and the network data. So once we took the network list and bumped it against our golden records, we then shipped those results to our call center partner, Command Direct, which we'll get into briefly here. So we wanted that extra layer of confirmation and testing to really make sure we were confident with our more data-driven results. So what did it look like when we identified these ghosts? And this is our initial reading from the algorithmic AI-driven matching approach. So here's our network data from FHIR, bump it up against Convergent using all of those data sources. And we're looking at things like typically a provider's address and a provider's phone, just the basic building blocks to see, are these data elements existing within the golden records? So out of 412 providers that we looked at, 191 were identified as ghosts. It's not quite the 86% identified by the OAG, but still a decent number. So we wanted to then test those results against manual verification. So this is where we did focus outreach, and Gary and his team with NYHPA went through meticulously each provider that we identified as a potential ghost, and we wanted to double check our algorithm to ensure it's accurate for this specific behavioral health use case. And this is when the actual manual validation kicks in as that additional layer. So of the 190, there's one left off for some reason. I'm not sure why it got squished out there. We had a 93% accuracy ghost prediction rate for this sample. I'm not a data scientist, but this is a pretty solid A grade for the algorithm. And the neat thing here too, and we'll go into what the team found in their observations when conducting this study, because I think there was some really interesting things that NYHPA and Gary's team identified when conducting this outreach. So we'll get into that in just a minute. But obviously a 93% grade is something that we can be pretty confident in when just looking at it from a more algorithmic standpoint. So as I mentioned in the initial part of the agenda, Now that we've identified and recommend suppressing these ghosts from the network, you might take a huge adequacy drop. So how do we go about replacing these providers with actual real providers who are accepting new patients? And this, once again, is where claims data comes into play. We can look up against networks and against the claims data that is not publicly available, but aggregated by Michael and his team at HDA. We can look at that and say, well, who are the providers that are actually practicing that meet the specialties and criteria for non-ghosts, and new providers that can be brought into the network who are not currently in the network. So this is an example of a study that we ran actually fairly recently too, in conjunction with this, where we're looking at the count of the NPIs available in the claims, and then the count of the providers that it overlaps within two different networks. And what we found is that there is often a gap between who the providers are that are actually active and accepting claims and who is in the network. So what you can see here between this difference between the 37 and 30, for example, there's 7 active psychologists that are not in Health Plan A's network. So that could represent a possible bump of providers who, are active, accepting new patients, could be brought into the network to replace the accuracy removal of the ghosts. And just another example of that here, where we can look at it from an organization level too. Who are those providers in network? And who are those providers out of network that we could bring in? So now let's get into the observations that we identified throughout the manual aspect of the ghost busting. So I don't know if Neetha is back on here. I know she was having some trouble with her.
I'm here.
Okay, you are here. So Neetha, I was hoping, as the person who was closest to this, running the call center and calling these providers, could you perhaps walk me through a couple of these examples that stood out to us as key observations?
Okay, yeah. So I had quite a few providers where I would call and they would say, they don't see anybody in person. They're just virtual. Some of them I could verify, and some of them I was unable to because you'd have to go to a website and register and all that. I was taking it from a secret shopper point of view, so I did not get on and verify all that because I wasn't actually shopping for a therapist or anything. But a lot of them I did find are virtual now instead of seeing patients at actual locations, even though they had a location listed. There were a lot of inactive providers. I would call and they'd say, yeah, that person hasn't been here in years. I'm not sure why they're listed. So, but I ran into that. And then the ones that are only available for certain individuals, there are a couple of providers who only see patients inpatient, like in a skilled nursing facility. So unless you're in that particular skilled nursing facility, you could not see the provider. And then the other major category of those was school-based providers. So if you went to a particular university, that provider sees those students, but they don't see anybody else.
Gotcha. Thank you, Neetha. And yeah, I think I want to drill in on the virtual providers with locations listed. I think that's a common thing. And Ron, you actually had some commentary on this before, where I think you were mentioning how that's potentially tied to a billing address issue.
Right. I think a lot of providers, when they need to enroll in payers networks, they need to submit some type of address. And, if the payer has an ability to differentiate between a billing address or an administrative address versus an actual practice address, then they have the opportunity to suppress those locations that shouldn't actually be listed in a directory. However, many payers just don't have that option to differentiate that, hey, this is only a billing address or it's only administrative. And so because they don't have that ability, the provider will just submit whatever address they have, which is an administrative address. And a lot of times those get listed in the directory, unfortunately. And I think that explains why we see what we're seeing here. So, hopefully a helpful note to payers who may be listening. It's important to differentiate and be able to suppress addresses that need to be suppressed.
Sure, thanks, Ron. And Michael, as part of your looking at the claims data from some of these inactive providers, I think you'd noticed some claims volume that really wasn't present for quite some time. So do you mind adding a little commentary on that as well?
Yes. So one thing that we'll do is for each of these providers, we will look at the claims history we see from them, and we'll stratify it by time. So in some cases, have we ever seen claims for this provider? Have we seen claims for them recently? And using that, we can determine if the provider is not seeing patients or if they've recently stopped seeing patients. And in some cases, they haven't seen patients in over 10 years, like in one case that we found.
Yeah, I think that's a really interesting, aspect of this ghost busting coalition is, each data set sort of has a unique attribute that helps add texture and color to identifying, whether this provider is actually accepting patients or even submitting claims in that example. So yeah, thanks, Mike, and appreciate you elaborating on that. So let's keep rolling. I think we're getting to Q&A pretty soon. Oh, right. So next, what we want to talk about before we get to Q&A, sort of what is a future free from ghosts? What does that look like? And I know I saw in the Q&A already, providers not reporting changes or misrepresenting where they actually provide services. That's definitely a common challenge. And I think we can dive into more of that in the QA, but I think this really speaks to this paradigm shift away from attestations that I'm really championing, and the team here is as well, where we have these different unique data elements and combining that with the power of AI and different algorithms that are enriching and deduplicating and surfacing all of this novel data to help us, remove the abrasion that we're seeing providers deal with. I think we sometimes, see things from our side of the picture where the provider's not updating their data, or that's, really a challenge, and it is. And there's simultaneously, there's always a flip side of that coin where that provider might be totally overworked or not interested in accepting new patients. So how do we surface that information without only having to rely on the manual verification efforts? And of course, we can outsource and do manual verification when it makes sense, but doing it in a way that is simultaneously leveraging big data to shrink the requirements of manual verification. I think there's a huge opportunity there, and something that really, that I think the case study showed, we can scale this out to more and more plans in New York. The benefits of sort of comparative advantage, where instead of the health plan having to do this internally and send folks and resources to do that, we have a dedicated team of Ghostbusters who, is solely focused on this challenge. And then actually coming full circle to what I initially wanted to speak with Eric about, is this idea of a state mandated single submission format for all providers. It's something that other states like Illinois, we're seeing implement successfully. I think New York has laid the groundwork for this with the PNDS report, There are some challenges with the PNDS report. And if we wanted to require all providers to submit via that, it might be too robust, essentially. Might be too much data required there. So is there sort of an alliance between these stakeholders, providers, health plans, folks like that, to reduce this abrasion, which also ends up having the result of improved accuracy, timeliness, completeness, and reduced abrasion. I think I said that. So let's get into the Q&A. I think, Eric, did you want to sort of take over at this point?
Sure. Yeah, sure, Jake. And really appreciate the insights and of the presentation, and thought it was a powerful presentation, given the challenges and discussions that we've been having since the Attorney General's report came out last December. One of the questions, and again, just a reminder to folks, if you do have a question, please make sure to put it in the Q&A function at the bottom of of your screen. One of the before I jump into sort of my specific questions as the moderator, we do have one comment in the Q&A just about how providers don't report changes or misrepresent where they actually provide their services. Jake, I think in thinking about that, sort of what does to address those types of issues, what does a typical engagement with a health plan look like, for this type of an effort?
Yeah, that's a great question. So typically, we'd like to take a more consultative approach because each plan is really unique. That said, we're all dealing with common challenges, and that's where I think our approach of busting ghost is really scalable and cost efficient when looking at that type of engagement. So typically what will happen is we start with the network and a data sample. And what we do is we run that through our algorithms and identify a prospective report, suspected ghosts. So once we have that, we prioritize them based on what we call our confidence score. So the confidence score is basically a composite data score that weights how likely that provider is to be a ghost. So it's sort of an additional layer of granularity that we're looking at a field by field basis. So if their license is inactive, the address doesn't match anything we have in the network, and our data, we're not seeing commercial claims, we're not seeing any claims volume, those providers would be ranked as the highest suspected ghosts. And we'd either run them through, depending on the client, our call center with the folks command here, and Neetha and her team, and to run that extra level of granular manual verification. Some folks need that to go to bed at night and sleep well, or all of that data and reporting can be sent back to the plan and processed per their requirements. Additionally, I'd be remiss not to mention, our core product, Convergent, is essentially an automated provider data management solution. So instead of just sending the data and the reports back, you can use the product to manage all of the provider data of a health plan in this more automated fashion that leverages the verification results embedded within it. So that if you're integrated with the data management system, it reduces the burden for the health plan of taking the data back into their systems and putting it all in the different places, the claim system, the suppressing from the directory, all that stuff is then taken care of through the data hub, if you will. So yeah, that's a high level summary, but thanks, Eric.
Sure. And then, Jake, and I'll open this up to the, the broader group here. Do you have examples of, can you speak a little bit to, how or where aligning on a single data submission format providers is working, but also what what the provider's response has been to this? Because one of the issues that we've talked about with the Office of Mental Health around could we address some of these provider directory network type issues through a centralized portal has been engagement around the providers. And certainly I think one of the things we've heard from our members is the data is only as good as what gets submitted back from the provider. There's, as you pointed out, outreach attestations, but give us a little bit of insight as to the provider's perspective and examples of where this approach might be working.
So certainly, Eric. I kept this slide in the back of the deck because I suspected this question might come up, and I wanted to point to this example of Illinois, where NYHPA, the Illinois Association of Medicaid Health Plans, has created a breakthrough statewide roster, and it took a lot of work aligning stakeholders around this, and a lot of design up front with alignment on what's in the roster, what are the fields there. And Samantha Oldsfray in Illinois, sort of the champion of this, and it actually ended up proving a lot of hypotheses we have about sort of interoperability, if you will. And what that means is when you align on standards and reduce the amount of friction and abrasion the providers have to deal with to submit data, it actually has the compounding effect of improving accuracy of that data. So if a provider needs to fix data in one location, they're not having to play whack-a-mole with all the other rosters that they have to submit. It also improves things like claims accuracy. That's been a big benefit. And then, of course, the member experience. What data are the members seeing in the MCO, specifically in Illinois, directories? That data tends to be more accurate as well, and the member experience has improved markedly through that effort.
Jake, on that point about Illinois, can you give us a little bit, just one piece of clarification? Do plans have? It's not a uniform roster per network per se. Each plan has its own. I'm assuming, or does each plan have its own individual network? You're just utilizing the same basic format for submitting information.
So another great question. So there are still challenges in Illinois. For example, Blue Cross, they have edited the roster essentially and said, well, we actually need these additional fields. So it's not perfect, but because of the upfront effort undertaken by NYHPA and incorporating all of the stakeholder feedback, the roster is very robust. There's over, I think, 130 fields just on the practitioner side. There's a lot of data there, but it does encompass all of the requirements that the health plans receiving that data, with the caveat of Blue Cross. It is covering all of that data.
Okay, great. We did get one additional question in through the Q&A. The question is, how is the golden record set kept up to date? Wouldn't it be subject to some of the same issues the regular roster deals with today?
So I think that's Ilya. That's a really good question, Ilya. Let me pull up this image here. So you're right. We definitely still use rosters as a data source within the golden records. So this is where our ability to enrich that data kicks in, and to even verify that data live. So in order to keep those golden records up to date, obviously we're setting up automated pipelines, basically taking in data of all different sources whenever it gets updated. So meanwhile, we're simultaneously running our verification and sort of like ghost busting process asynchronously, and that we have different golden record rules that are set up to take in the results of those verification processes, to essentially promote either data sources or results from that process as higher ranked data that appears as the golden record. Whereas if we're overwriting or suppressing an element that came from a roster, the system allows us to do that as well and to keep that up to date within the system. So that's a really good question, and it's definitely a complicated answer, but I think it's it's a complicated issue too. Thank you, Ilya.
right. Other questions from folks? We'll give it just, we'll give, oh, here we go. One last question. From Heather, based on your findings, do you believe your results would align with the Attorney General's report? Although I think you guys have touched on that a little bit, earlier on, right, Jake?
I think to a degree, yeah. Good question though, Heather. I think the AG report, I do not believe, published the providers that they identified as ghosts.
Yep.
So it's hard to tell based on who was in their data sample, who was in our data sample. I think our results showed a little more forgiving of a picture, where I think we're at 46% ghosts were identified, and our call center is meticulous, and we don't stop at the first sign of a speed bump. So Neetha, I don't know if you have any more commentary on sort of that process that was undertaken to verify that information.
So I did try to reach different providers, and if I didn't get anybody who could verify the information the first time, I gave it another try, or I would talk to them and say, just see if they have any idea where to go with that. But it was, most of the information was inaccurate, so they didn't really go anywhere.
Yeah, and that's mainly the result of the algorithm sending you suspected ghosts. So that's sort of the algorithm surfacing the suspected ghosts and getting those out there. So we would expect call center to basically bump into most ghosts. And I think the other aspect of this too, during any engagement, we work with Priority Health in Michigan for this, where we found 23% of their primary care providers were in fact inactive. And I think, there's a difference between the AG doing a report and somebody on the health plan side, trying to, look at this in the lens of more of an adequacy aspect, where you're saying, well, this provider, it might be challenging to get in touch with them at the moment we're speaking with them. But in fact, they are active. They are seeing providers. It's just maybe their front desk person is new that day, or they didn't have the right answer. So we are able to be persistent and do that to try to salvage as much of the network as possible. And the flip side to that too is using data like claims. You can really get a view into the truth of the matter.
But Jake, as your data showed earlier, I think the Attorney General's office has shown about 86%. Your case study showed about 46% on ghosts. But utilizing this type of tool, you expect that that 46 number would probably come down even more, pretty significantly.
Yeah, that's right. If you were able to proactively implement a process like we're talking about, we'd expect to essentially eliminate those ghosts. And so the network would be free of those ghosts. That's right.
And I think just one final clarifying question, Jake. I'm not sure if you're able to answer this, but as far as the work that you all did, were those providers OMH OASAS clinics or group practices?
Well, I'm curious why you asked that, Heather. It's a great question. I'll have to follow up with you and look back at the data that we worked off of and the sample we used. So also just curious, it seems like there might be an underlying reason for that question as well, though. So I'm curious what that might be.
So Jake, if you want to put your email address in the the Q&A so folks have it in case there's additional follow-up questions that folks are looking at.
Right.
We'll give that just a moment. In the meantime, I think unless there are other questions from the membership. All right, hearing none. So look, well, thank you all for taking the time to join us today. Jake and company, we really appreciate the insightful and informative conversation on an issue that's really top of mind and one that we as an association and as an industry continue to work on. As I mentioned, as I mentioned earlier, we'll be sending out to all attendees a copy of today's presentation along with a link to the webinar itself. Additionally, we'll be including an evaluation form so that we can get feedback on the webinar and any suggestions that you as the members have for future programs. With that, for folks who want to maintain the Ghostbuster theme and are looking for something to do this weekend, as a reminder, Ghostbusters Frozen Empire opens Friday, March the 22nd. In the meantime, thank you all for taking the time to join us. We really appreciate you carving out some time out of your busy schedules and look forward to talking to you soon. Thanks, everybody.
Thank you.